Now, coming to the diagnosis of carcinoma esophagus. Carcinoma esophagus can be diagnosed by esophagography, CT scan, PET scan and MRI. Positron emission tomography, PET scan and MRI. Another method of endoscopic, well, that is the radiologist, those were the radiological methods. Now coming to the endoscopic methods by endoscopy, endoscopic ultrasound and endoscopic mucosal resection. There is another method or there is another thing required for carcinoma esophagus diagnosis is minimally invasive surgical modalities. These minimally invasive surgical modalities are not common everywhere in the world. We will come to it. Now coming to the esophagography. Why do you want, will we do an esophagography in a patient with carcinoma esophagus? When will we do esophagography? You see in esophagus, in carcinoma, sometimes even in advanced stage, the patient with carcinoma esophagus presents with dysphagia, or sometimes the presenting symptom of the patient will be dysphagia. In that case, in order to evaluate the dysphagia, esophagography is a classical first investigation. If the presentation is dysphagia, you can see in the esophagography, you can see a classical apple correlation in esophagus. This is the picture of an apple correlation in esophagus. Now the next is endoscopy. How does endoscopy help in the diagnosis of carcinoma esophagus? Next line of investigation is endoscopy. In endoscopy, we can see what is the type of the lesion there. What is the type of the lesion? Is it friable or anything? What is the will the lesion is going to bleed? These are the, is the lesion is bleeding? Is it ulcerative? Is it ulceroproliferative? Is it a fungating lesion? All this we can find from endoscopy. Suppose along with this we can take a biopsy in endoscopy. Other things which we should see in endoscopy are, suppose when we pass the esophagus endoscope, first we will reach the cricopharyngeal junction, then we will reach, suppose here it is in the tumor is suppose here. We should also know the distance of the tumor from the cricopharyngeal junction. Another thing we should know that how much does this extend, how much does the tumor extend in the esophagus. Next, we should also know the distance of the esophageal tumor from the gastroesophageal junction. We should know whether it is invading the gastroesophageal junction or not, whether it is a G junction tumor or not. And finally, when the endoscope reaches the stomach, we should see the distensibility of the stomach by the air in the endoscope to make sure that the stomach is not involved by the gastroesophageal junction tumor or the lower to 1/3 carcinoma esophagus. Next is the computer tomography. How does computer tomography help in diagnosing carcinoma esophagus? It is a routine investigation. You can see the tumor in the esophagus here in CT scan. What all will we understand other than the diagnosing the tumor? If you see the CT scan, we can understand the upward spread of the tumor. How much does the tumor spread upwards between seeing the different cuts of the esophagus? How much does the tumor spread lower down? These are the things we should see. Then we can also see how much, whether there is a radial spread of the tumor, whether the tumor is invading the surrounding structures. Next, we can also see the lymphatic invasion of the tumor and also whether there is any liver metastasis in the CT scan. So these are the information we get from CT scan. Another thing is PET scan and MRI. PET scan has a bit more increased sensitivity and specificity than CT scan as far as the tumor is concerned, but PET scan is not that much helpful while reading the lymph nodes. So more CT scan and PET scan can be used together to better delineate, to better stage the carcinoma esophagus. Next is MRI. The role of MRI in esophageal carcinoma is less, but MRI can be helpful to diagnose vascular or neurological, vascular or nerve invasion as far as the carcinoma esophagus is concerned. Say hoarseness of voice or aortic involvement, you can use MRI. Next modality is the endoscopic ultrasound. In endoscopic ultrasound, what happens in endoscopic ultrasound? In endoscopic ultrasound, we are seeing a cross section of the esophagus. Suppose this is the esophagus. If we keep the ultrasound probe there, we are seeing a cross section of esophagus as we see in the picture. And in that cross section, we can see the scope, and we can see the scope head, and we can see the tumor in case of endoscopic ultrasound. What all additional information does endoscopic ultrasound gives? We can clearly see the different layers of the esophagus in endoscopic ultrasound. The submucosa, the mucosa, the muscularis propria, and the adventitia can be clearly seen in the endoscopic ultrasound. This helps in the more accurate T-staging of endoscope with the help of an endoscope. It can also help in taking a biopsy, endoscopically assisted biopsy. Another is, you can see that we can already see a T-stage, you can already see the tumor there. We can also assess the lymph nodes. Lymphatic staging can be also assessed in endoscopic ultrasound. That is another use of endoscopic ultrasound. Now coming into the endoscopic mucosal resection. This is again helpful. Endoscopic mucosal resection, what we do is, we inject saline submucosally, raise a wheel in the esophageal mucosa at the carcinoma site, at the site where there is a high grade dysplasia or at the suspicious site. Then we use a cup, suck that mucosa and a part of submucosa, and use a snare to cut it out. So what is important is that this part where we take, we are all getting a mucosa and getting a part of mucosa and a submucosa. What is the use? It can be helpful in diagnosing the stage of the carcinoma esophagus. That is regarding the endoscopic mucosal resection. Now another is endoscopic submucosal dissection. Here what we do is that we start a bit away from the lesion in the esophagus. All these are done endoscopically, mind you, and we go to the submucosa, take the lesion along with some part of the submucosa. What is the advantage is that it helps in a better staging, but it can also help in therapeutic purposes, especially in small lesions or lesions of high-grade dysplasia lesions. Now, minimally invasive surgical modalities. Again, these minimally invasive surgical modalities are helpful in diagnosing and staging of esophagus, carcinoma esophagus. The minimally invasive surgical therapy include bronchoscopy, endoscopy, mediastinoscopy, thoracoscopy, and laparoscopy. Now, what is the use of this bronchoscopy, thoracoscopy? Bronchoscopy can be helpful if you want to know there is a tracheoesophageal fistula, if there is a tracheal or bronchial involvement. Thoracoscopy can be helpful to understand the radial spread and can be also useful to assess the lymph nodes. Mediastinoscopy can be helpful to the pretracheal, paratracheal lymph nodes are involved. Mediastinoscopy can be helpful, or subcarinal lymph nodes are involved. Mediastinoscopy can be helpful. We can take biopsy with the help of the mediastinoscopy. Laparoscopy is another investigation. These are the minimally invasive surgical modalities which we use in carcinoma esophagus. Now coming to the staging of carcinoma esophagus. All these investigations, this CT, this PET, MRI, endoscopic ultrasound, everything is done to finally stage the lesion. So what is the new AJCC staging of carcinoma esophagus? You can see, suppose the lesion is involving the mucosa and submucosa, it is T1. Even if only mucosa is involved, if mucosa plus submucosa involved, the lesion is T1. Suppose the lesion is involving the muscularis propria, it is called T2. Suppose the lesion has crossed the muscularis propria and reached the adventitia, it is a T3 lesion. And suppose if the lesion has reached, is involving the surrounding structures, suppose the lesion is infiltrating into the surrounding structures, it is a T4 lesion. Now, how do we stage this? N0 is no nodal involvement, N1 is there is nodal involvement. So, if it is T1 N0 lesion, it is stage 1. So, mind you, the N0, N stage in esophagus, if there is a nodal involvement, it becomes N1. If there is no nodes, there is no nodal involvement. But T1 N0 is stage 1. T2, T3 and T4 is a stage 2A lesion. T1, T2 and N1 is a stage 2B lesion. And T4, T3, T4, N1 is a stage 3 lesion. So suppose the lesion is T3, N0, M0, it is a stage 2A lesion. But if the lesion is T3, N1, M0, it is a stage 3 lesion. So by these methods we can diagnose stage the carcinoma esophagus. So that much we will discuss today regarding carcinoma esophagus. In the next presentation, we will discuss regarding the treatment of the different stages of carcinoma esophagus. Thank you.